Thank you for the opportunity to talk at this meeting. I'm going to speak about HIV-associated comorbidities in adolescents in the era of antiretroviral therapy. The pediatric HIV landscape has evolved in a substantial way. The remarkable global scale-up of antiretroviral therapy for children has dramatically improved survival, and combined with the decrease in new infections due to prevention of mother-to-child interventions, this has resulted in an increasing proportion of adolescents in pediatric HIV clinics. But it's important to note that the coverage of antiretroviral therapy in children is still low and lags substantially behind that in adults. And there's been delayed diagnosis. So many adolescents today did not start antiretroviral therapy in infancy. And this has bearing on what I'm going to talk to you about. So if we look at the global epidemiology of HIV in adolescents, this was a meta-analysis that was done by the CIPHER collaboration of the International AIDS Society and included nearly 40,000 adolescents, of which 79% were from Africa. What you can see is that the median age of ART initiation in Africa is much higher than that in USA and also in Europe. So nearly 8 years when children were starting antiretroviral therapy. There's also higher loss to follow-up and mortality in sub-Saharan Africa. And ART initiation in Africa is done at much lower CD4 counts than in children in high-income settings, as you can see from the second panel in the middle. And on the third, on the right, what you can also see is that the height for age scores, i.e., which is a marker of growth, linear growth, is also much lower in children from Africa. Let's have a look at drivers of HIV-associated comorbidities. So there are a number of reasons for us to see that children, despite ART, are at risk of having a number of comorbidities. One of the reasons is immunosuppression. There is sequelae, consequences of serious recurrent infections, for example, chest infections. We know that there is a compromised protection from normal childhood vaccines. And we've also been observing malignancy and a higher risk of premature malignancy, particularly from viral related tumors in children growing up with HIV. A second important aspect is the pro-inflammatory effect of HIV. So despite antiretroviral therapy, which suppresses suppresses viral multiplication and allows the immune system to restore, we also know that HIV has an effect on immune activation, systemic immune activation, which is reduced by antiretroviral therapy, but not completely suppressed. And this is particularly affected by the timing of infection and timing of antiretroviral therapy, and can lead to multiple organ complications. A third reason for associated morbidities is antiretroviral therapy itself. There is a difference in the way children process drugs, and they have an immature physiological system when they start drugs compared to when adults do it. And we also know that they start and are on exposure to drugs for a longer period, at least a decade longer than adults would be expected to do. And one particular morbidity that cross-cuts all of these drivers is psychiatric morbidity. Not only do the other three factors that I've spoken to you about affect and cause psychiatric morbidity, but there are also social factors, psychological factors, and neurocognitive disease that increase the risk of psychiatric morbidity. And that speaks to the very complex psychosocial landscape that children are growing up with. And all of these factors can result in increased disability and potentially also increased risk of death. This is just an example of one study that has looked at multi-system impairments in children growing up with antiretroviral therapy. So this was the CTAC cohort from Cape Town. And what they did was they looked at HIV positive adolescents who were positive and those who were uninfected. And what you can see is that the risk of dual and multi-system morbidities is much higher in adolescents growing up with HIV compared to those who are uninfected. And that substantially high prevalence of multisystem morbidities, with the common ones being cardiac disease, respiratory disease, neurocognitive disease, and renal disease. So really something that we need to focus on over and beyond viral suppression in adolescents who have grown up with HIV today. This is just showing you some manifestations. These are some of the kind of more visible manifestations. So on the top left panel is a 14-year-old who's had long-standing seronegative arthritis. And the panel on the left below is again another adolescent who's had multiple corneal infections and has had corneal scarring with resultant blindness. In the middle panel at the top is a CT scan of a lung of a child with an adolescent with chronic lung disease. And this particular form of lung disease is very different from the one that we used to see in the pre-antiretroviral therapy era, which was lymphoid interstitial pneumonitis. In the era of ART, we predominantly see small airways disease, which causes cough and exercise and hypoxia, or lack of reduced oxygen levels and lack of the ability to do exercise, and is very difficult to detect on routine examination, and something that children just learn to live with, and often does not come out as a prominent complaint, but is really very disabling. Skin disease, chronic skin disease, this particular one, planar warts, does not respond very well to antiretroviral therapy and is very, very visible on skin, and stunting, as you can see in the child on the right, who's 16 years old and is very stunted. This results in a lot of disability. This is a study that was done in Zimbabwe comparing positive and negative adolescents, very well immune reconstituted with a median CD4 count of 726. And what you can see across all domains that this was related to much higher prevalence of lots of domains of disability, and an odds ratio of 2.8 for any disability in HIV positives compared to negatives. So what are we going to do? Essentially, we need to increase timely diagnosis still of HIV. HIV programs need to shift beyond focus on HIV care and viral suppression. We need to have increased awareness of morbidities, and we need to understand their natural history and pathogenesis. We need to develop screening, diagnostics, and therapeutic strategies, and we need to have a bigger focus on management of disabilities and focus also on educational support and mental health interventions. I'd like to thank you for giving me the opportunity to speak, and we'll be very happy to take questions. Thank you very much.